the American Medical Association pursuit of an ICD-10 CM code for that, and that we'll go into more detail on that shortly. And then, as we've long planned for addressing concepts in toxic stress, and to balance all this, addressing concepts and protective factors. Welcome everybody. This is the beginning of a few months cycles of work, and we're really there are a lot of planning went into this day. Next slide. We do welcome all of you. I said that now. And so we start with participants muted, but there's plenty of time for open conversation throughout, and specifically on this meeting. During this meeting, and specifically at this moment in time, we are going to have some very, open conversation, just given a need to reflect the tenderness and ethics of this moment. The call is recorded. All calls are recorded in Gravity, and they're located on the Gravity Confluence for reference of our open consensus work. You can find this meeting and meetings from our prior sessions again on the Confluence. As we move towards our open work, I do want to make sure that everyone knows you can leverage the chat. Again, I think I've now coined the phrase, we operate by formal processes, but in informal ways, right? So we act more as a seminar than anything else. We really try to reflect and listen to the moment at hand and make sure people feel seen and heard. And so please send chats to everybody. And if you have a question, if it's respectful to pause, we will do so. And again, I leave that to the expert presenting to decide whether they should hold the question to the end or whether it can be addressed in that moment.
Sarah.
Hi, Lucy.
Hi, I'm sorry to interrupt, but there's something in the chat about somebody using AI meeting notes.
Yeah.
In other settings, there are rules against that, and it's not comfortable for me to see this. What is the policy here?
You can, so the person who has, thank you so much for that. Especially I think given the work we're ahead of time and given that the meeting's available after the fact, if we can disable AI meeting notes for this meeting, that would be appreciated. Thank you, Lucy.
Thank you.
And again, I think, and if we can just monitor Sarah and just try to make sure that that gets turned off, that would be great. Okay. Anyways, please send all chats to everybody, just so we can see. And again, as the sometimes facilitator in this work, again, you're going to be seeing a lot of different leaders as we go forward. If it's sent to me, I will read it out loud because I have a hard time discerning what's to everyone and what's to me. Next slide. And I think we are an open standards initiative. And so our job, we have like rules that we comply to as a standards-based entity. And it's basically that we have the responsibility to comply fully with federal and state antitrust laws. So as we move forward in this work, it rarely comes up because of the focused and particular nature of the work we do here. But please, anyone speaking or providing information, please refrain from any discussion which may provide the basis for an inference that they have agreed to take any action related to prices, services, production, and allocation of markets, or any other matter having a market effect. Again, this does not come up usually in terminology. Sometimes it comes up in an implementation affinity meeting or tech meeting, but just noting that this is the antitrust practices we are bound to follow. Next slide. Great. Welcome, new friends, and welcome old friends as well. This is not a typical kickoff for very important reasons, right? To be responsive to this moment in time, and also to address to level set on the requirements of proceeding in these particular domains. So usually we share lots of content, and but we are setting ourselves up more for a conversation. Again, the content will come. So the agenda is we're going to have welcome and announcements. We're about to get into announcements. I've already offered the welcome. In order to introduce new individuals into the work that we do, we are going to ground ourselves in a bit of the what and the how, right? So what is Gravity Project? Where are you if this is a new meeting for you? And the domains we will address in our 2025 spring, winter, Corey, 2025 work. And then we're going to pivot. Again, usually we present a lot of content on, health associations, but really because of the unique nature of our relationship, specifically with the American Medical Association as a longtime member, and also because of this moment in time, there's going to be a pause to reflect on histories and relationships. And then again, because of the tenderness and sensitivity of at least two of the concepts, again, that we're addressing today and over the course of our work, protective factors is by design the antidote to much of the complexity what we're going to be talking about today. We're going to be going into some shared community agreements in order to do this work, and then again reflected to this moment in time, because we are operating in an open consensus space. We wanted to have a brief conversation on holding space for collective consciousness and action, specifically referencing some of our foundational conceptual frameworks as we do this work. And again, I want to note that deep thanks for all the subject matter experts who've helped to date. And you're going to be meeting some of the leaders in this work as we go forward today. But again, very deep gratefulness for the subject matter experts who's helped guide our approach that we're having today as we go forward. Next slide. The next slide. We do just want to note that Gravity has 3 different work streams. We'll go into the what of that in a little bit. The technical work stream, reviewing the implementation guide and talking in concepts in FIRE, just happened yesterday. It happens every other week, Wednesdays 1 to 2. It's led by my colleague, my partner in the good, Corey Smith, who is our technical director, who's here today. And is known to many of us. Implementation workstream, the cadence of that has changed. A note to everybody, again, because our initial focus is on implementation, we're just getting people to do the codes, like using and piloting, and now Gravity's written into legislation and regulation. So we're shifting our focus a little bit and really focusing on new and innovative use cases, applying Gravity standards, and it's only quarterly. The next meeting is February 27th. And then we are speaking at WEDI, the Health Equity Virtual Conference, and you'll see us at HIMSS for those of you who are attending. And that's where you can find us in the weeks and months ahead. Next slide. Just trying to follow the chat as I go. Any questions on the announcement section? Okay, next slide. I'm now going to go into, again, for those of you who are new or anybody who's been here before, we always try to ground this work into what we do. We haven't put our vision on our slides before, which I think is an omission. And so we wanted to make sure that we level set in our vision again, especially at this moment in time. Usually we talk about what we do. Our goal is to address data standards, to develop data standards, to address the social determinants of health. But the vision of why seems critically important at this moment in time. The Gravity Project striving to create a world where health and social care organizations readily share the information needed to effectively meet the social needs of individuals, advance health equity, and improve outcomes in communities by using standard terminology and technology, right? That's our goal. Our goal focused on health equity has not changed. Improving health outcomes has not changed. And it just seems like it needs to be stated at this time. Lucy?
Yeah, thank you. I think all work in the HIT sector avoids any suggestion that technology has to be standard. So I'm wondering whether in the last line, using standardized terminology and technology would be a better expression of what we're hoping for. We want to see certainly standardized terminology I don't know about standardized technology. Maybe Corey could comment about that. But
Well,
technology varies across, technology variation is infinite. So we are trying to overlay infinite technological variations with standardized terminology. That would be my understanding of what we're doing. Thank you.
Lucy Johns, you are a Gravity member. You are part of our strategic visioning session where this vision came out of last year. I encourage you as a member to bring those beautiful, wise thoughts to that strategic session because you are always insightful and on point. So if you can, so this is crafted by members. And so I can't change it now, but luckily we know we're planning a session to revisit our strategic goals at this moment in time. And so I love that you brought that up. And I hope that you carry that forward into that meeting.
Another platform is more appropriate. Thank you for bringing that up. Okay.
Okay. And I'm really lucky that you are one of our designated members and advocates because you are amazing. Okay, next slide. Thank you.
Hello.
Oh,
Sorry to interrupt, Sarah. This is
hi,
Elizabeth
Liz.
Valencia.
Yeah.
I can't find the little hand icon.
Okay. Hi.
I will find it here shortly. And I'm
Okay.
still trying to get a feel for the cadence of how we interact. It's a great presentation. Loved Lucy's point. I think that's an important distinction. I just want to share that the impact from my perspective is that technology is held accountable to reflect the consensus standardized terminology. And so in that regard, and I know it takes some wordsmithing and finessing, there would be standardization for accountability on what technology is providing from an interface standpoint along the continuum of care, billing, ICD codes, et cetera. That's my comment. Thank you.
Love it, Liz. And then the great thing is some of American Medical Association is also a member of Gravity. And Liz, thank you. And we'll capture all these comments and then make sure that we, again, revise our vision when we convene in just a few weeks to revisit it, which is very timely, Lucy. We are going to be convening in a few weeks to revisit it, and so we'll make sure we include all of your wisdom in that work. Sound good? Thank you, Liz. And Corey, you heard it, right? No, Corey. Okay. Any other thoughts?
Yes, I did.
Okay. And I think Corinne's on the call too. So just she's listening in, our project manager. All right. Any other thoughts on or reactions? And again, this is the great thing about finally putting the vision on a slide. It was hidden for a very long time in a piece of paper on a confluence, right? The point of elevating it in open consensus places is we are accountable to it. So thank you for offering insight on how we can improve it, right? Go team. Anything else? Okay, next slide. This is our, folks know that I tend to get the ethics of this are very dear to me. So if I get a little emotional, it's just the nature of the game. So a grounding lexicon, the why we're here, and it sets the stage really for everything we're about to do today. Health equity, very simply, it might be a hot topic unnecessarily, but it's really just the state in which everybody has a fair and just opportunity to attain their highest level of health, right? And our role within that is to develop data standards to support addressing needs and elevating protective factors. Social determinants or drivers of health are the conditions in which people are born, grow, live, work, and age. And they are, by evidence, shaped by the distribution of money, power, and resources. You'll see it later, but one of the foundational conceptual frameworks we use in our work is the World Health Organization Conceptual Framework for Action on the Social Determinants of Health. It's there at the end of the presentation, so we'll revisit the why of how that happens, the distribution a little bit in that slide. It's important to note that social determinants of health or social drivers offer both positive and negative forces. And this is kind of the encompassing nature of what we're addressing today. Anybody can pipe in. I'm surrounded by experts. I'm just reading slides. But finally, I think we've been planning to do this for just years. We're addressing protective factors, which are the characteristics or strengths of individuals, families, communities, or societies that act to mitigate risk and promote well-being and healthy development, right? So I work in family practice. I specialize in pediatrics, and I do trauma-based care and harm reduction as an addiction medicine specialist. I cannot do my work without talking to patients and families about protective factors every day. It's part of what we do. Core to the work of social work. Again, strengths-based perspectives. We are well accustomed to addressing and naming the negative forces, right? Adverse social conditions associated with poor health. And then social needs are those patient prioritized social risks. So this is the lexicon of that we work within. Health equity is just when everyone has a fair and just opportunity to obtain their highest level of health, protective factors, and social risks and social needs. Next slide. Gravity, again, I just mentioned, I've been talking about members, so Gravity has a pretty novel membership model. It's based off, really social justice community action work. We certainly have, sponsors who give funds to support the critical work that we do. And you can see many friends in our premier partner and associate level sponsorships. It's kind of a normal HL7 accelerator model. We are unique in that we create space for designated memberships who are critical to the work of addressing social needs and risks. Again, these are patient experts, community-based organizations, direct service entities. Again, the experts in many experts in service provision and in conceptual frameworks, and so our model includes both. Again, we're the only HL7 accelerator that has patient reps consistently as part of governance, so really glad for that. Next slide. We have 3 work streams, and I've mentioned this again. We're just doing an overview before we get into the content. We've mentioned them. We have the terminology work stream, which is where we are, right? We are language makers. We create concepts and encoded concepts to tell critical stories. And we collate that information into value sets, which are just collections of language that can be used for multiple purposes. Where we meet our friends in the technical work stream, and again, when I say friends, Gravity is a team of staff of like less than 10. We're tiny, is in the standards for exchanging that information in FIRE, which is really critical as we look forward into addressing barriers in technology. And then we have our implementation work stream, which is where we test and explore what we have and how to make it better. Next slide. Over the course of our inception in 2017, I was just at the Social Intervention Research and Evaluation Research meeting in San Diego. That's where I was over the weekend. Siren convened a panel with Academy Health in DC, and I was there in 2017. What did we need to address social determinants of health within clinical practice? And it was said that we needed an entity to develop open consensus data standards, and then Gravity was created. We've addressed multiple domains since our inception, and in the same process that we employ today, and have a few different iterations of our implementation guide in FIRE to address those needs. Along the way, we've become part of critical policies and regulations, such as the United States Core Data for Interoperability, referenced by the NCQA HEDIS, social needs, screening for social needs measure, the SNS measure, and most incoming CMS guidance on instruments and data standards point to Gravity as well. Next slide. Our 2025 roadmap, what we're doing as we go forward is addressing both new domain work and enhancements, as we call them, in our terminology work stream. New domains, again, for this work are protective factors, terminology to name racism, and toxic stress. And then in the fall, convening subject matter experts to address food access, neighborhood safety, and likely topics and environment, but likely focusing on climate. And then we always are trying to improve our work, includes developing HCPCS codes for food as medicine initiatives. That's the coding for food work. That happens on the next meeting. So this meeting every 2 weeks. And then next week is the enhancement cycle. And we're also working to develop terminology to document eligibility and enrollment. We're developing an open classification of social care programs to be a standard in line with the Health and Human Services data strategy, right? So always trying to improve and lean in to solutions to support, really to address barriers to addressing social needs. Our technical work stream is kicking off new use case exploration and constantly refining the IG. Join Corey in the meeting on Wednesdays. Again, it was just yesterday. And then our implementation affinity group is, again, that last, happening quarterly, kicking off on this month now, February, the end of this month, and focusing on real world use cases using gravity terminology. Busy roadmap. Next slide. We would not be able to ethically do this work ahead of us if we didn't develop data principles that recognized the principles of data justice and social justice in our work. So in our very inception, we created data principles that we call the Gravity Data Use Principles for Equitable Health and Social Care. Again, leveraging the literature of data justice, leveraging the wisdom of community action, data sovereignty, we crafted these principles, which include improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and significantly, importantly, preventing, reducing, and remediating harm. These principles have been with us since our inception. We apply them to everything we do. And we even use them and weigh them when we're thinking about building language within this work. If we feel like the risk is too great, we do not build it. If the ecosystem is more likely to cause harm as we anticipate bias and harm, we elect to not build it, like just as we did with incarceration status in the fall work. Next slide. Any questions on the general gravity work that we do? Thank you, Lucy. Okay. Next slide. All right, so again, we're not going to do as detailed a kickoff. Usually we do every single domain and have named subject matter experts and have slides. It's a little bit different because of this moment in time. So we're going to go some overviews of, we have a couple general topics on what we're addressing, and then we'll go into some unique concepts because of the domains we're about to address, and just wanting to make sure everyone feels supported as we do this work. Next slide. Next slide. Oops, I think maybe our slides got picked up a little bit. Next slide. I think there's an order, so we can go forward. This is just denoting our support we have with Registry, a 4-year grant. Next slide. And I'm sorry, I think the goals slide got mixed up, so I'm just my order brain is adapting. So the terminology work stream, what do? We develop and curate data standards for standardized assessment instruments. We name diagnoses or assessment concepts. We name goals that are critical for patient-centered care planning, and we build terminology to address all core social care programs and human services programs relevant for that domain. And these are the domains we've addressed to date, and we're kicking off the 2025 domains right today, and then we'll get in the fall. Next slide. How we do that? We do that in a process called the Gravity Terminology Curation process, and this is the formal part of our work. It is now soon to be published process, which is part of creating data standards that are trusted both to name things appropriately, but also to be based on the ethics and evidence of social determinants of health. We always leverage the evidence, including literature and subject matter experts. We craft them in consensus, as we are doing today. We consistently leverage the terminology expertise in the community that predates us. Healthcare terminology may be new in this space, but social care and human services terminology likely is often there ahead of time. A good example of this is the work that we did to ensure all of our housing concepts supported the homeless management information system, or ensuring that we name all core programs for the administration of children and families appropriately. Same thing with USDA programs, right? Always leaning in to the definitions and really requirements, program requirements of the community, human services and social care community. And then we are principled, right? So this is, I just mentioned this, we're always grounded in the ethics of data justice and social justice as we move forward. Always. 2 6-month cycles. And we're just beginning the public work after months of preparation. And then we're aiming towards a vote at the end of May. And then after that, after we develop language needs and we have our consensus vote, then the Gravity team kicks into build mode, and we work directly with coding entities to submit concepts, likely one of which will be, supporting, the AMA request for an ICD code here to support that work. Next slide. So the questions our SMEs are set to answer, and you all will help us answer as well, are what are the standard instruments used to identify the domain at hand? Standard instruments to identify experiences of racism and discrimination, standard instruments to identify protective factors, standard instruments for adverse child experiences and toxic stress. What are the core diagnoses that need to be stated for that, both high-level ICD-10 concepts, like for classification, the highest level, and then specific SNOMED concepts that represent subtypes or key facets within that high-level concept. What are the goals that we have as we're working with people, trying to help them? And then what are the things we do, both the care team and the person, to address that risk or condition? Next slide. This is the example of it applied to food insecurity. So encoding the hunger vital sign, developing ICD-10 concepts for food insecurity and SNOMED CT concepts, developing goals to use in care planning. And as I mentioned, encoding all core federal programs and rules that matter. So whether it be WIC, food as medicine initiatives and programs, encoding community health worker as a concept. That's the work that we do and the work we have ahead of us. Next slide. And as I mentioned, all of that language then gets collated into value sets for ease of use. They're collated in the National Library of Medicine, accessible simply with a login. Although some of the terminologies do require licensing for use, they're all gathered in that space. And then they're able to be used for multiple purposes, whether it be population health, quality measures, QI projects. Anyway, they're all there, and they're all curated by the Gravity team for uses both in the IG and in patient level and population care. Next slide. All right. Okay, next slide. All right, so I, again, am just going to use this slide to set it off the domains. Usually we have multiple presentations by our subject matter experts. In this instance, we have a different kickoff at this time, and then very shortly I'm going to pass the mic to friends. We are focusing on person-level experiences of racism, which is basically terminology to tell the story of how racism, racial and ethnic discrimination influences health. Person level, because through structural lenses, racism is also measured in marked differences in outcomes and opportunities, right? So that's why that person level tag is important. And it's built off the AMA request for an ICD-10 CM concept for racism in spring 2024, and we'll talk more about that shortly. We are developing terminology to name and tell the stories of toxic stress, so terminology to tell the story of how significant stressors, discrimination, witnessing and experiencing emotional and physical abuse, separation and isolation, financial insecurity, etc., in childhood otherwise known as adverse childhood experiences, can change the physiology of the body, leading to increased rates of both child and adult health concerns. And in order to address toxic stress well, we're also going to be holding space for how the physiologic effects of toxic stress may persist beyond childhood, especially within chronic socioeconomic stress and racism, a concept entitled weathering. And finally, we're going to be leaning into protective factors to tell the story of how we individuals and care teams counter chronic stressors with strength building, and that's highlighted, and structural support. So not only assisting the person, but protective factors can also be the fact that they are enrolled in and receive food stamps, that they have a Section 8 housing choice voucher, addressing socioeconomic risks structurally. Examples of these are self-sufficiency, cultural connectedness, social connection, resilience, self-esteem, faith, financial security, and connection to core financial stability programs. This is a core part of all child and family care, hence the deep presence of pediatricians as experts in our work. So I appreciate that question, Marianne, and we'll get, I think next meeting, do we have one of our SMEs? We're about to go into the uniqueness of, if one of our subject matter experts feels comfortable, next meeting, I'm going to hold that question, Marianne, and get to it next meeting, and center it then, just because I don't want to put one of my SMEs on the spot. Is that okay? All right. And then I just wanted to note, closing it on protective factors, that protective factors are a fundamental perspective and intervention in the profession of nursing and social work. I already mentioned that before. Strengths-based assessments. You know, I talk with my friend Elena Kalinowski about this all the time. And you're also going to see in our work many social workers, right? So you're going to see lots of pediatricians. You're going to see lots of social workers. Our subject matter experts building off of the focus of their profession. Any question? Again, this is Lucy, yeah?
I have read that voting enhances health, and I'm wondering if voting is appropriate to be added to this first dash under protective factors.
I have not seen that as a concept that's been identified as a protective factor to date, but I'm happy to explore it. We will address that with our SMEs, if that's okay.
Thank you.
And I think we did have voting as a domain itself, like voting as a determinant in our sandbox area. Any other questions on these domains? Okay, next slide. That's just a nice visual from the Wisconsin Department of Health Services that I love regarding protective factors. Next slide. Guiding questions as we go forward is really trying to figure out whether one code and concept is enough to encapsulate both racial and ethnic discrimination. And we're going to be exploring whether, and these again, leading up, our subject matter experts are already talking about this. Are the physiologic effects of adverse child experiences and weathering similar enough to share a concept and approach, or need to be called out separately? How will standard goals and intervention terms be structured within a protective factors framework? Like, we do this work every day, like every day. You know, we will hopefully be pulling in the American Academy of Pediatrics, Bright Futures, screening items. Every single time I do a well child check, I do a protective factors assessment, standardized by the AAP. So it's going to be interesting to see how the problem-based focus of standards might need to be revised to represent assets and strengths. Next slide. This is important to note, and partly why you hear me pivoting. Given the sensitivity of these topics and the current significant cultural stressors, and the fact that many of our SMEs are experiencing direct stress at this time, we gave all subject matter experts the option of being anonymous in public spaces. Many chose this path, too many to call out the few that were felt safe enough to name themselves. So until right now, going forward, until anything changes, we just want you to trust us that we've gathered a humbling set of the nation's experts, and there's a few who you will see centered here consistently, but many did not feel safe enough to name themselves. And we're going to be exploring that in a little bit more closely as we go forward. But I hope by now that you trust that they are here and they are guiding us, and that our main objective is to keep them safe.
Sarah, I just have to say that all the work that you have done and all the leading that you have done the last few years has created such a well of trust that when you say what you say in this slide, I don't see how anyone could say you have to do more, or we don't trust this, or I don't understand why you're saying that. I think this is a very moving statement that you've made in this slide. And I just want to say, for some people who haven't been here as long as Gravity has been going, that your leadership has created the potential for all of us to trust you in this.
Thank you, and that means a lot, Lucy, and I'm grateful that we make that space together.
If this had come up only 2 years in, I think the reaction would have been, wait a minute, we want to know who these people are, and all of that usual stuff that we have become used to. But this is protective for them, and we have to trust you about this, and I personally do. Thank you.
Thank you, Lucy. It means a lot. Okay. Next slide. This is a very factual slide, and we're going to get, Lucy, I have friends in this work who are coming back to help as well, who I trust with my heart, who I'm glad to have back with us as well. So this is the timeline starting today, aiming for the end of May. And again, timelines can be flexed. If it takes time, we shift. So just noting that this is just a rough guide, that doing the work well and ethically and carefully is more important. Next slide. Okay, any questions on the work? That's the what, and then the how is a little different, and so we're going to go into that next. How is shifted, and there's like an ethical how, and then there's a historical how. Okay, next slide.
Sarah, before you go into the next section, I had a
Yeah.
question to put out there. Just thinking about the group that Gravity has gathered here, and just all of the multidisciplinary expertise that we have on this call. I was wondering, can you say a little bit to the group about how maybe if someone has not been working in the standards or the technology or the coding and nomenclature space, can you say a little bit from your point of view about why or how you might feel that their expertise is valued in this space for this work, for these particular topics?
Yes, I can, and thank you for that question, Kenya.
You're welcome.
I will do my best, and I also know I have many friends who can probably do a better job than me. I'm going to start because you asked me. That's partly the reason why I use the word story, right? Certainly, we're aiming for terminology and data standards, and that can seem really opaque. Like, what does that mean, right? And the reason why data standards are important is within the work of caring for people, within healthcare settings, the complexity of human stories that we're trying to tell necessarily get reduced to codes, right? And Gravity was started because there were significant gaps in the language and the words that matter to tell critical patient stories, to critical person stories. You do not have to be an expert in data to be an expert in storytelling, right? You do not have to have ever put a code into a health record. Like, it is not, you can be completely oblivious to the data that underwrites the work that we do. If you know how to tell and name critical stories, if you know how to help people in communities, if you bring that lived experience of a person with an idea of how you wish your story to be told, Gravity's job is to help turn that into language that can be a data standard. So anyone with any story whatsoever, whether it be personal or professional, any area of knowledge, that's what we work to glean here. And then our job as terminologists is to assist in making that into the codes that become the standard. The entry level is not informatics, the entry level is human. And then we go from there. Kanina, was that a good answer?
Absolutely, Sarah, and thank you. And the question is meant for any of our colleagues who, feel like they might have something to add to the answer to that question as well, Sarah.
Anything remaining to be said to answer Kenyatta's really critical question, which I think is actually really important. Ash, I don't want to call you in, but that was like one of the things we were talking about as well, is like how people who have really critical lived experience and expertise can feel welcome in this space, like how to de-jargon it, right? Because it's really just about the stories we need to tell. The data is just a means. It's just a method. Any other thoughts?
I apologize for my tardiness in arriving late on the scene here. I had some other issues to attend to. However, to support Sarah's statement, allegory plus data equals possibilities. For those of you that love formulas or you're interested in that, the allegory, the stories have to be able to create a schema or change. So those people who are spending a lot of time attempting to code recognize that the code has to inevitably be bidirectional. It has to help the patient and it has to help the provider. It has to help the team. So to Sarah's point, we're asking the living experience to be fluid. So whatever we do here is going to create a living experience. It's going to continue to move and grow in the capacity of which the patient, the provider, the community experiences what it is that we do here. So it's foundational work, yes. And the living experience of the subject matter experts that are here are also the vicarious living experiences of the communities in which they share. So my hope would be that however we work together, we're directly and vicariously also supporting the communities that honor our ability to be in this space. So thank you to your point, Lucy, of naming Sarah's leadership. And I would argue and offer to everybody else, thank you all for your leadership. Thank you all for your stamina and your possibilities and wisdom.
Question, you made me, as you always do, think deeper. And then Kunyata, I want to lean into something that we know is actually the goal. So I'm talking about stories, but I also like action and advocacy, right? So we're talking about person level stories. Gravity's third use case is aggregation for structural change, like population health analysis, data to drive policy, right? So I don't, again, if we think about the World Health Framework, World Health Organization conceptual framework, that we address person level needs and we advocate for structural solutions, right? So data is critical if we're thinking of any structural solutions and policies, especially at this moment in time. Any other thoughts? Again, so many experts in this room. Grateful for all of you. Kenyatta, are you ready to go into the next section? This is you, friend.
Yes, thank you, Sarah.
There is a unique partnership that brings us here at this moment and sets the stage for this work. So this is a brief grounding in that. Next slide. This is the top line. Kenyatta is going to go much more eloquently into over the next slides, but suffice to say, AMA has been with Gravity from its beginning. And both have been working kind of in tandem, planning. And I just want to note, as Kenyatta is going to go into the next slides, specifically into the moment that brings the AMA and her here. I want to note that Gravity, and Mark, I see you. Gravity has been planning to address these domains for years, right? So given our evidence-based foundation and vision towards equity and outcomes, Gravity's been planning to address domains of racism, toxic stress, and protective factors since our inception. And these domains have been collectively, consistently prioritized by members. And were prioritized once for work in 2022, and then again recently. It's our honor to leverage our curation process to support Gravity member AMA and our many members at this moment in time. And we'll go more deeply again into the three domains and how they're interrelated in the next meeting. But we wanted to honor Kenyatta in this next slide. Kenyatta, I pass the mic to you, friend. Next slide.
Thank you, Sarah. And hello to everyone. I know we had a really short time together today, and I really look forward to learning what everybody does and who we all are on this call. But I will say that I'm very happy to see you all here. I think this work is a culmination of a number of relationships among all of us, and some work that has been underway for some time. I work at the American Medical Association. I currently sit in the Center for Health Equity. I've been in the center for about a year and a half, and prior to that, for about 3 years, I sat in the American Medical Association's Health Solutions business unit, where I work directly on infusing health equity into the data and technological work that the AMA does from the perspective of coding and nomenclature. Many of you may be familiar with the current procedural terminology code set. The process for that is facilitated by AMA. The convening around the edits of the codes, the management of the codes, and the adoption of new codes is managed by that previous business unit that I worked with. And I had the fortuitous occasion to collaborate with Sarah and some others on this call on some of that work before migrating over to the center. So I want to share with you over the next few slides some of the work that Sarah kind of foreshadowed for us from my point of view as a public health professional who has come into this medical organization. And just thinking about, medicine's what I called complicated relationship with population health, because just largely for the day-to-day function of physicians from the point of view of AMA, because the AMA serves physicians. This is really true for a lot of care providers. They deal with individuals quite often, and quite often are not working with families or communities collectively. But as well, you know, in the history of medicine, particularly in the United States, there's some problematic history with regard to specific populations. And so in 2018, as a result of some policy, the American Medical Association began to be committed to advancing, learning about, I should say, beginning to learn about what health equity is and committing some of its resources to advancing health equity. This was not the beginning of the organization's relationship with this discipline. There have been a number of colleagues within the organization that had worked on health equity and population health issues that came together and worked with some of the policy sections of the AMA to encourage the formation of a Center for Health Equity. Some apologies for some historical missteps, some acknowledgments of those missteps, and that work continues now. And so thinking about medicine's equity journey, I just wanted to make sure that we think about, you know, those points of departure. Racism has often been embedded in some of the historical aspects of the very organization. For example, I have, you know, individual physician members as examples. The example that I use on this slide is J. Marion Sims, because I think that example is accessible to many of us on this call. J. Marion Sims was credited with being the father of obstetrics and gynecology. He was also once a president of the American Medical Association. And it's just maybe in the past 5 to 10 years began to be discussed widely in the social sciences and multiple disciplines that J. Marion Sims performed many surgeries on enslaved women of African descent without anesthesia, you know, which was really torture, and then was credited in his findings with being the father of obstetrics and gynecology, which is also arguable given some other history from antiquity, particularly Egyptian history. But that's just one example. In some other problematic movements within the United States, and I say in the United States because I want to make sure that I'm contextualizing that we have a whole global environment where health equity unfolds, and that in each of the areas where people are living, some of these narratives are slightly different, but a lot of the root causes are similar or the same. Another thing that I would point out is that formerly we have a data set from the American Medical Association that used to be known as the master file. Now it's called the Physician Professional Database. But some of the collection of those data historically were used to exclude physicians of color from membership of the American Medical Association and also from practicing as physicians in the profession. So those are some of the things that kind of have come before this commitment by the AMA to health equity. In 2018, through the process, the policy process of the AMA at the annual House of Delegates meeting, a policy called the Plan for Continued Progress Toward Health Equity was introduced. This report included a definition of health equity, an initial framework that outlined the AMA's role in addressing inequities in healthcare, a recommendation to develop an organizational unit such as a center to initiate, facilitate, coordinate, and track AMA health equity activities. And the report and its recommendations were adopted as AMA policy. So the following year, the Center for Health Equity was launched. And I'd like to acknowledge that another colleague from the Center for Health Equity is also on this call, Dr. Camille Williamson, and a number of people who are on this call who were instrumental in some of this policy and some of this activity. I'd like to acknowledge them too. And we can go to the next slide, please. Thank you. So this policy that's on the slide is just one example of, some policy that began to be generated into the AMA's policy process. And we saw just more and more policy that made the work for the Center for Health Equity huge. Lots of activity for us to work out and report upon. And this policy is important because it is affecting change in a lot of organizations, a lot of different agencies, and we see some of the backlash against that now. But this particular policy had to do with removing racial essentialism from the language of medicine. And racial essentialism is basically the idea or the thought that race is a biological concept, and that based on one's race, that they may have a difference in their biology, which is not true. Race is a social construct. So this policy was called the Elimination of Race as a Proxy for Ancestry, Genetics, Biology, and Medical Education, Research, and Clinical Practice. And AMA recommended that clinicians and researchers focus on the experience of racism and social determinants of health when describing risk factors for disease. Please, we can go to the next slide. Thank you. So these next steps are a little bit more pertinent to some of the work that Sarah mentioned earlier. One was in 2022, the policy restricting derogatory and stigmatizing language of ICD-10 codes was a coding and nomenclature directive. And the AMA just promised to work with certain organizations, including the National Center for Health Statistics, ICD-10 Coordination and Maintenance Committee, to advocate for the World Health Organization to adopt destigmatizing terminology in ICD-10 and future ICD codes, and to eliminate existing stigmatizing diagnostic synonyms. This was huge because ICD is a global code set that is used for describing diagnoses. The CPT code set is used for billing and reimbursement. So they have two different purposes in the practice of medicine. And CPT is mostly used in the United States. Although some other countries have adopted the use of CPT for billing and reimbursement. But ICD, in my opinion, helps us understand diagnoses and helps us to compare diagnoses across different settings. And so this was an incredible policy to undertake. I'm aware that one of my colleagues, Nancy Spector, who's not on this call, and Corey Smith, who is on this call, have been instrumental in helping the AMA to advance some of this policy, some of the actions of the AMA to affect change in some of these organizations, and therefore across the healthcare ecosystem. So the CEO of AMA wrote a letter with huge assistance from our colleagues to the CDC for the creation of a code to be heard at this Coordination and Maintenance Committee on including a code about racism. So along with existing and emerging nomenclature, allowing physicians to delineate the patient experience along social dimensions, the proposed update to the existing code Z60.5 was to be heard by that committee at the request of Dr. Madera. And Nancy and I worked together with this committee to request that we present in March of last year to request this code to be added. We can go to the next slide. I want to be a little bit careful about mentioning the details of Dr. Madera's letter, although I thought, I wish you all could see that letter, but I don't have permission to share it. But I just think, just saying that I think that was an incredible action that's kind of under the radar, that the CEO of an organization like this was actually reaching out to add this adjustment so that patients, when they go to a physician, they can say, well, I feel I have hypertension. because of persecution and, discrimination. And that code could be applied then theoretically to their medical records. And then that would allow for researchers to explore the use of that code across healthcare in the United States and across the international communities to understand how often patients attributed discrimination and persecution to their healthcare problem. So that was the significance of this action. I did present on this in March of last year to the committee. Sarah, I think Sarah was present and some of the other colleagues from Gravity because they were also presenting on some code modifications. And what ended up happening was that this proposal went up for public comment. And during the public comment period, the 3 comments that were added to the request for this code were that folks thought that Gravity were doing this work, not necessarily realizing the strong relationship between AMA and Gravity. And so Sarah had a great idea, and Nancy and I agreed. I think Monique, who's on this call, was a part of those conversations to why don't we work together on pushing this code proposal back in front of the committee in September. And so a part of the reason for us coming together is to work on any refinements we want to make in this application. And coming together as a collaborative, we're thinking that that might result in the successful addition. Of course, we didn't know some of the factors that we would be facing early in the year, and also some of the factors that some of our colleagues at CDC and NCHS would be facing. So we'll see how this goes, but I think that this work is significant. We can go to the next slide. Thank you so much. So I think I can pause there and just see if there are any questions from the group based on what I've shared. We can certainly talk more about this in other meetings, but we just wanted to give you a summary of, some of the work that had been done um, from this perspective. Lucy, I see your hand. Please go ahead.
Yes, Kenyatta, this certainly is not the AMA that I grew up with, and I have to congratulate you for this, you and your colleagues for this extraordinary work. Thank you.
Thank you, Lucy. Do we have any other hands? Oh, Camille, I see your hand. Please go ahead.
Thanks so much. I just wanted to say thank you for offering this introductory meeting. I'm one of the colleagues, just so everyone knows, I'm one of the colleagues that works with Kenyatta at the AMA. And I can definitely say I appreciate anyone's confusion or concern or congratulations in terms of how we're trying to move things forward. I'm really excited to engage in this work. The questions that I have are primarily around, and I may have to go back and look at some of the slides, but is there room for other sources to consider in terms of how we make these determining definitions codes? And because some of the things that I think we're used to using don't necessarily have as comprehensive and inclusive uh, testing of validity. And sometimes jargon is a barrier for some of the people that we work with. And so I have a sensitivity to that. While we have all types of terms, definitions, et cetera, I have found that sometimes they don't necessarily explicitly capture how a person is making meaning of their health and the etiology of what disparity they might be experiencing. And I view these conversations as political, but I think everything is political. And so I'm hoping that that is not something that is problematic or nuanced for anyone. As I understand, uh, sometimes some people view saying this is political or I don't, or not wanting to get political. I think everything is political, and it behooves us to be mindful of that and to think in a number of different facets and perspectives about how to move this work forward in a way that, similar to the first comment about using the word standardized, um, in a way that is reflective of forward movement and not the moment, or not just the moment.
Yeah.
Thank you.
So absolutely, Camille. I think that that is a part of the purpose of us coming together, is to think about how to refine some of the terminology, and even to think about strategy and approach to discussing the language in these requests. Of course, there will be some external factors in terms of how we develop that strategy. And I want to just pause and allow for others to also offer answers to your question and your comments. Yeah.
Yeah, I'm going to try to answer a process answer, just as a welcome. First, we fundamentally expect that communities and people are the best experts of the experience that we're trying to address and name, right? So fundamentally, as we uphold like standards of evidence and literature, we also lean deeply into the experience of communities and people, right? So we are not bound and never have been bound solely by, ivory tower concepts of things, right? So just insofar as like in the initial question, we are habituated now this far in our process to exploring knowledge in all of its forms, right? And so that I hope that welcomeness and the community co-creation principles of what we do are clear from the get-go. And then just lastly, I think it's important to note that we wouldn't be able to address our third use case, which is aggregation towards the purpose of structural change, without politics, because that's fundamentally about policy, right? So we note that that's part of what we do, and we're humble in the fact that what we do is often leveraged quickly because of the care and because of like the representation and consensus nature of what we do. So it's not at all inappropriate to include community expertise, patient expertise, alternate forms of knowledge. And it's the expectation that we think about how what we are creating could be leveraged towards policy in every moment in time, both within that last principle, both from a policies of harm and policies of good perspective, though.
Can I add one more thing, and then I see Janice's hand also.
Yes.
There was a taxonomy of different dimensions and domains of experience that we thought about proposing at this meeting. So they would include things like sexism, things like persecution or discrimination due to sexual orientation or non-binary identification. There were some other dimensions in that taxonomy, and we had an inclination to propose the entire taxonomy when another colleague was joining us to discuss this, and we decided to go forward with just going with race and making that application as strong as possible, and then going back with the others. So I just wanted to make sure that I shared that with the group as well. And Janice, please go ahead with your question.
Yes, thank you for this. I really appreciate that we're doing this, and you know, it is a different landscape right now. We'll see what happens. I looked up the Z code 60.5, and it states that it is currently, I don't know if that's true, can be used for reimbursement purposes. But in the there's a little explanation. What does Z 60.5 mean? And the second bullet states, this can include discrimination based on factors, skin color, religion, or ethnic, like you mentioned. I do think it's smart to have one called out just on racism. Interesting, by the WHO, it says it's a factor that influences health status and contact with health services. And they go on to further explain it kind of could help clinicians understand patients' social needs and connect them with resources. But that would be some of those would be pretty challenging. I don't, you know, to connect somebody with resources for anti-racism is not something that most clinicians would have on hand. Anyway, I just want to add that. I'm just curious if you know if it has been used much or if at all, right? I mean, just a Z 60.5.
That was a question that we asked Janice of Tracy Martinez, who was working with us. I don't think there's been a strong study of the utilization of the Z60.5 code. So I think that would be very useful to undertake. Not sure of the bandwidth of this group to undertake that utilization study, but I definitely think it would be a powerful thing to do. And I think that your question is an excellent question. I just don't know the answer in terms of any compelling study of the utilization yet.
I'm gonna share it for sure because like refugees and immigrants too are population that are really experiencing this right now too. So thank you.
Absolutely. Thank you too. And another thing that came up during the presentation were distinctions between race and ethnicity. With, you know, ethnicity being interesting, especially in other countries, because people can be, you know, have the same level of melanated skin, but be of different ethnicities, and there could be persecution for that reason because of, you know, some differences in culture and ethnicity. So the person was asking, were those not the same? And my answer to him was that no, they were not the same. And so I'll turn it back over to you, Sarah, and thank you all so much for your attention to this section.
And thank you for your leadership and expertise. I want to note that Kenyette has been a guiding light in this work long before this kickoff. So thank you. Okay, I think we're going to shift. We have a couple more sections to address. Again, next time, plan to come back and do more of the in-depth look at some of the instruments that we use to identify these concerns and really holding up some of the protective factors and ACE's work. And we'll hear from Smeeze on that, but we wanted to make sure that we really thought about this moment in time. And I think we're already feeling it based on the comments, but level set in some of the agreements we need to have as we proceed. Next slide. Just level setting again on the principles. We said them early. They're really important to hold now, right? And just thinking about this moment in time and as we go forward. Next slide. It does not need to be said that as with our work on incarceration, the Springs domains will consistently highlight structural and harmful truths. We can anticipate this, and it doesn't, like, both in the topic of racism and in the topic of adverse childhood experiences. And there's a lot of, you know, Marianne brought it up earlier, but there's a lot of trauma in these words, right? And in these concepts, and we can anticipate it. Mark, I see you talking about other aspects of discrimination. And again, I hope, that we're accountable to addressing them in time. And we definitely hold space, especially in this moment, for needing to circle back around. We thought that we scoped it to here, to this moment, really just for this particular moment, but know that we have to circle back and do other domains of discrimination later. Okay, so many of our subject matter experts in our community and ourselves come into this work with lived experience, right? So whether you're thinking either of the racism domain or the adverse childhood experiences domain, toxic stress, there's a lot of trauma in those words, and many of us come into it with those feelings, especially now. So we must craft this space thoughtfully and carefully, highlighting truths and doing the work without causing additional harm. Respect and care is always the expectation when sharing the space with each other. It's even more important now. And we ask that you take care of yourselves and take care of each other as we do this work. Just because we have important work to do. And I want to note, and Lucy, I'll get to you, really grateful, and Kenyatta is amazingly, we're really grateful that particularly for helping us navigate complex conversations, Dr. Kwesi Bote is back with us. So very grateful for you. We just knew that we needed to get into this work intentionally and with focus. And Lucy, oh no, Linnell, it's Linnell, sorry.
Yeah.
Yeah.
Hello.
Hi. Yeah.
I'm, me, I'm known to throw out a few ideas, but as listening to this, and as many of you know, I work at Blue Cross, so we've been studying the current landscape a lot, and I've been personally studying the landscape. I want to throw something out for you, terminology experts, to consider. I know we're talking about ICD-9, ICD-10, Z codes, but I would encourage you to see if there's any way that LOINC codes could be an interim workaround. The reason is the Reagan Street Institute is run by an African-American woman that I used to serve on the board. I'm no longer on the 807 board, but I know she is very familiar with this work, very supportive of this work. And depending on where her funding is and what may or may not be a funding risk for her, and just so all of you know, just like other government contractors, HL7's not getting its payments from the feds right now either. So as a non-for-profit, it's possible that the Reagan Street Institute, given their leadership, that may be more open to these concepts than the normal federal process to do Z code updates. That may be something this group should consider as a real world option. And I say that without having had a chance to talk to Sarah offline to see if she thinks that's even feasible. But realistically, as we deal with the current political reality, LOINC becomes a place where I'm at least sure the leadership of Reagan Street would welcome some discussions on topics this sensitive, is the thought for all of you to think about.
Thank you.
Thank you.
It's not needed because it's expected. Every single concept that we address is not just ICD, right? We thank you so much. You're correct. We have our partnership with Reagan Street sets us up for that, but we're highlighting the moment of ICD because of the request of AMA, right? We will build in LOINC and SNOMED as well. Our SNOMED concepts are all evaluated for international use, right? Those LOINC and SNOMED, as our job as an accelerator, we have intentional relationships with them as well. There might be a political nature to ICD-10 CM because of the entities that manage the CM extension of ICD in the US, but fundamentally, LOINC and SNOMED are open, agnostic, international standards, right? So as much as we lean in to support the request for that specific ICD-10 CM, that is not the sum of our work, right? We have a lot of work to do across all the terminologies. We're just elevating that at this moment in time. But yes, correct. and expected. I hope that's a good answer.
Oh, that's fantastic. I'm sorry we didn't have a chance to touch base before I said it, but I figured it was relatively safe in this environment.
Everything, well, no, not everything's safe in this environment. We're being a little bit more intentional in that. But before we go here, can we go back for a second? This is our closing section, and we only have like 7 minutes. But Kwesi, do you have anything to say again, just regarding on the concepts of proceeding without causing additional harm and the shared community agreements? And again, sorry to put you on the spot. I just wanted to give you space at this moment.
Thank you, Sarah. Thank you all for your stamina and availability to be present, because I think that it's important just to state that we're present. And also, I think it's important as we move forward to recognize that we have 4 R's, which may have been covered before I got here, but we're talking about what our roles, our relationships, our responsibility, and our resources are. So we all have different variable roles that bring us into the space. And when we are here, knowing what our roles are together and individually is really important and salient. The second piece might be, as we understand our roles, what's our relationship to those roles? And how are we resources not just to the project and task at hand, but to each other? Oftentimes we will say, take care of yourself. Really, we don't define what that might mean. That's very open and loose when someone says, take care of yourself. I will offer to everybody in the space, think through what taking care of yourself means on the front end, on the back end of the meeting. So I don't book meetings after this, because it's important for me to breathe and exhale out what we just took in together. And it may mean that there's other spaces in which I need to be mindful and present of why I am here. Unfortunately, today something happened that was kind of critical that I needed to be available for. I often tend to give myself a good half an hour before we start these meetings, so that I can be fully present and grounded, and to ensure that I'm available to all of you in a way that's meaningful. Now, everybody can't do that. It's similar to the way I say everybody can't go to the march, because people got kids at home, or they got somewhere they got to be. It doesn't mean that they're a part or they're moving forward with the movement. It just might mean that there's some other things going on for them. Can we be mindful of what that might mean in this space? And then we can all hold space for each other in ways that are meaningful, so that our allegory, West Africans often talk about, we talk a lot of stories. You know, we have a lot of ways in which we have analogies. Camille, to your point, our analogies also have to be clear so that people can make decisions about the schemas that change. So if we can think through what it might mean for all of us to care, also understand we need to be clear, have clarity, be consistent in our communication, and think of it the opposite way as well. So as we offer things to each other, let us affirm first, attune second. What does that mean for you as you affirm someone or something you're saying? And the third piece is allow space, because it's okay that people don't talk so fast. You know, a lot of times people don't talk so fast. They might be thinking through something. Allow space. And just because someone, you don't see their face or you don't see them on the screen, doesn't mean that they're not fully present. It could be that, you're tired of looking at yourself. I don't know about all y'all. We got in this thing, and now we all got to look at each other over and over and over again. Folks just tired of looking at themselves because they've been on the screen for 5 hours. That's totally cool too, right? That's cool. Let us just be mindful of that. And my last point would be, we are more than the hue of our skin. We are more than our gender. We are more than our sisters. There's much more to us. Let us be mindful of what that means when we say that our identities are salient in the work that we are doing. There's much more than just this face you see. Let us make space for all of that, so that the work we are doing, and when we define it, when somebody gets to that code and says, I'm gonna click that code, they recognize the impact of clicking that code and what it's gonna do. Everybody cool with that? So if you haven't seen the Soul Train in a long time, I would encourage you to watch the last part of Soul Train, because Don Cornelius always ended with something I think that this group could take a lot away from. As in parting, Don would say, I wish you love peace. And he would throw the soul to the group. Let's just hold the Soul Train line, y'all, so that each person can walk through this line, and our job is to hold the beat. Feel me on that, people? Let's just hold the beat, because if somebody can express themselves in a way and that they're held here together, we can do something really cool. And Sarah's been really cool about holding, that space and running the music and inviting us all to the party. Let's just hold the beat, y'all, because we can do something really cool and set precedent. And I will take up that mantle for those that haven't done it. Janice, to your point, I think there's dollars at the university to do utilization study. So I'm gonna jump on that because I think that could be impactful to ensure that some kind of work like that is being done. And I'll pass the mic on to Sarah.
Thank you. Is it okay to say personal congratulations to our friend who defended his dissertation since we last saw you? Congratulations, Dr.
Got my little thing together.
You do.
Little sprinkle seasoning salt on these potatoes.
Thank you, friend. Okay. We are gonna, next time come back here. These are the shared agreements we're gonna be carrying with us as we do this work. We would not be doing a correct level setting if we didn't segue into the next bit. Next slide. Next slide. I'm trying to get to the, all right, so I just want to honor the fact that, Kenyatta, I made a slide to really just set up a conversation you wanted to have, but Gravity's founding model, I've mentioned it every single year since our inception. The founding model of my dissertation, was the conceptual framework for action on the social determinants of health, right? So we felt, Kenyatta asked, we agreed, I should say, that it would be remiss at this moment in time to not talk about what collective action looks like as we leverage this space to do our work and the work outside of this space. Okay. I want to note just some of the agreements and and principles in the why we're here. So the health system, according to the framework, is a social determinant of health. Oh, and Mike, I can't believe this is the first time I'm showing it. I don't think, maybe it's not. Literally, I talk about it all the time, and it's like my faith. Oh, it's all right. The role of the health system becomes, this is all quotes from the framework, which is a gorgeous piece of writing too. Whew. Yeah. The role of the health system becomes particularly relevant through the issue of access, which incorporates differences in exposure and vulnerability, and through intersectoral action led from within the health sector. The health system plays an important role in mediating the different consequences of illness in people's lives. And you can see health system circle back all the way to policy, right? Like you can engage in this work and not be political. Kenyatta, I don't know if you want to say anything else. I have a couple of thoughts I can close with, but I want to make sure that I give you room, wise friend.
Thank you,
Oh, it's
Sarah.
5:32. We're almost over time. You go. I'm so sorry.
I was going to say maybe in a future meeting we can spend some time with this. This was included in the proposal presentation that was last year as well. And so we can spend some time talking about context of the framework, if that's okay. I don't want to keep folks long beyond their half hour there.
That sounds great. So maybe what we can do is ensure that instead of just homework, we talk about action at the end of the next meeting. Does that sound good? Okay. I'm sorry that we somehow time got lost in my brain when Cressy was speaking and I just lost track of time. We are at time. We will revisit this. And I think we're ready to close out if we just go to the next works. Most importantly, I want you to know that all of our experts and their writings, we have collated them key literature to ground the why and the what is located on the Confluence. So we ask that individuals do their homework ahead of the next meeting. If you have any ideas and instruments, submit them. We'll be convening our subject matter experts for the first time. We've had a couple orientation sessions, but for the first time next week, and we look forward to seeing you in 2 weeks. This every 2 weeks here, addressing these 3 topics, and then every other week is the enhancements work. A huge thank you to everyone who showed up today. Thank you, Kenyatta. Thank you, Kwesi. Thank you, all of you, for your expertise. Thank you, Camille. All of you. Thank you so much for doing this work and holding space and caring for each other. And we will see you in 2 weeks.
Thank you, Sarah.
Thanks so much. Bye.
Everybody. Bye.
Thank you, Kenyatta.
Thanks, everyone.
Thank you, everyone. Appreciate it. Have a good weekend as well, or weeks ahead as much as we can have. So thank you.
Thank you. It's good to hug you, Janice, this weekend.
Oh, Sarah, I sent you that
Yeah.
doctor wrote to me. I sent you an introduction.
Yes, and I can't wait.
Anyway, take care. Thank you, everybody.
Bye.